Hello everyone. Today's topic of discussion is Scarlet Fever. So that is asked for 5 marks in the university, and there is Noma, which is also asked for 5 marks, sometimes 2 marks. So we're going to read these two in detail. Let's start with Scarlet Fever. And so scarlet fever is a contagious systemic bacterial infection. So scarlet fever is also a type of bacterial infection, which is why we're reading it under the chapter bacterial infection. Now, how does scarlet fever spread? Scarlet fever spreads via respiratory droplet nuclei, which is in direct contact with infected people. So if infected people cough, their cough expectorants, if it is inhaled by a healthy person, the healthy person gets infected with the bacteria. Usually it is associated with sore throat. Now coming to the etiology, what is the cause? So there are two causes. One is beta hemolytic streptococci and Streptococcus pyogenes. Basically these are the names of the two bacteria, that is beta hemolytic streptococci and Streptococcus pyogenes. These are the two bacteria which are erythrogenic, and so basically these bacteria have a toxin in them. The name of the toxin is erythrogenic toxin. Okay, erythrogenic toxin. Erythrogenic toxin is a toxin that is present in beta hemolytic streptococci and Streptococcus pyogen. This attacks the blood vessels and produces characteristic skin rash. So scarlet fever is mainly characterized with skin rash. That is because of this toxin, erythrogenic toxin, which is attacking the blood vessels and producing this rash. Okay, so the name of the toxin is erythrogenic toxin, which attacks the blood vessels and gives the characteristic rash. Coming to the pathogenesis, how it causes illness is, first, the strains of streptococci releases exotoxins. Okay, though what are those exotoxins? The exotoxins are A, B and C. Okay, the strains of streptococci release 3 exotoxins which are erythrogenic or scarlet fever toxin. Okay, strains of streptococci release 3 toxins. We read A, B and C. Erythrogenic or scarlet fever to erythrogenic scarlet fever toxins. Okay, now they produce a clear hemolysis around the colonies in the blood agar plate. Okay, so they produce hemolysis colonies in the blood agar plate. Now the local erythromatous reaction occurs in a susceptible individual. So it produces clear hemolysis around the colonies in blood agar, and local erythromatous reaction occurs in susceptible individuals. Now this is mainly a hypersensitivity reaction. Okay, so if they ask you, you can write that the pathogenesis is firstly mainly by the two bacteria, that is beta hemolytic streptococci and Streptococcus pyogenes. These Streptococcus pyogenes and beta hemolytic Streptococcus produce toxin, which is your erythrogenic toxin. This attacks the blood vessels and produce rash. So the streptococci also releases 3 exotoxins, that is your A, B and C. After which they produce, if we have to analyze, they produce a hemolysis around the colonies in blood agar. Okay, and local erythromatous reaction occurs in susceptible individuals, and this is a type of hypersensitivity reaction. Now coming to the clinical presentations of scarlet fever. Scarlet fever is a most common in children. It is usually seen in children only from 3 to 12 years of age. Then incubation period is 3 to 5 days. After this 3 to 5 days, they cause severe pharyngitis, tonsillitis, headache, chills, fever, abdominal pain and vomiting. Okay, so first is they cause your pharyngitis, then tonsillitis, then headache. So let's come from up to head to toe. Okay, so first is your headache, then is your chills, fever, headache, then your tonsillitis, pharyngitis, abdominal pain, and vomiting. Okay, so these are the symptoms. Your symptoms are chills, fever, vomiting, headache, abdominal pain, pharyngitis, and tonsillitis. Then there is enlarged and tender cervical lymph nodes. Okay, so the lymph nodes are enlarged and tender. Then coming to scarlet skin rash. What is scarlet skin rash? Scarlet skin rash is something that appears on the second or third day of the infection. It is prominent in areas of skin folds. What are your skin folds? Your thigh region, your cuboidal fossa. Then wherever you see your skin folds, there you can find a scarlet skin rash on the second or third day. This is a result of the toxin on the blood vessel, which produces dilation of the blood vessels and consequently hyperemia. Rash is blanch on pressure. So if you put pressure, it blanches. Okay, typically it begins on the first upper trunk, spreading to involve the extremities of palm and soles. Now small papules of normal color erupt through these rashes. So there are small papules of usually red color, maybe they erupt through these rashes, and they are sandpaper feel to skin. If you touch to the normal skin, they give a sandpaper feel. Now there is also something called Pastian's line. Pastia lines. So what are pastia or pastia lines? These are transverse red streaks occurring in the skin folds. That is the rash. The rash is like a transverse red streak. It is the color of the rash, which is scarlet to dusky red. Rash subsides after 6 to 7 days, followed by desquamation of palms and soles. Now coming to the oral manifestations, one important oral manifestation seen is stomatitis scarlatina. Okay, stomatitis scarlatina, what it is we will see. So it is a Forkheimer spots. Okay, so stomatitis scarlatina we will see, but before that we will see what is Forkheimer's spots. Okay, Forkheimer spots, the oral manifestations of the scarlet fever are also called as stomatitis scarlatina. Okay, now there is also something called Forkheimer spots, which are small punctuated red macules on hard and soft palate. So there are these small macules on your hard and soft palate. Then there is something called strawberry tongue, which has been asked a lot of times. So what is strawberry tongue? There are changes seen in the earlier course of the scarlet fever, in which tongue exhibits a white coating, and the fungiform papillae. The fungiform papillae are edematous and hyperemic. So basically, fungiform papillae become edematous and hyperemic, projecting above surface as small red knobs. So they give this red knob appearance. The fungiform papillae on the tongue give the red knob appearance. Okay, and this is your strawberry tongue. Okay, then on the 4th to 5th day the coating of tongue is lost. Okay, then at the in the 4th or 5th day the coating of tongue is lost in the beginning at the tip of the lateral margin. So it remains here, but at the here and the lateral margins and the tip, the coating is lost, and the tongue becomes deep red. The tongue becomes deep red and glistering, smooth, that is glossy and smooth, except for swollen papillae. So the centralized papillae are still very deep red in color. Other than that, the lateral parts and the tip of the tongue is it has lost its papillae. The tongue in this phase is known as the raspberry tongue. So there is strawberry tongue, where the fungiform papillae become knob-like and where they are very erythematous. Raspberry tongue is when the tongue in the center is red and swollen and glistering, and the papillae on the lateral side and the tip of the tongue are lost. That is your raspberry tongue. Now, complications arises due to bacterial dissemination or hypersensitivity reaction to bacterial endotoxins. So if there is bacterial dissemination, the complications could be peritonsillar abscess, so pus in your tonsils, then rhinitis, sinusitis, otitis media, mastoiditis, meningitis, rheumatic fever. Now the diagnosis. Diagnosis is a routine blood examination, CBC, and your marked leukocytosis with increased neutrophilia. So there is an increase in your ESR and C-reactive protein. Bacterial infection, then if there is a bacterial infection, the blood report has increased ESR, and if you get a C-reactive protein test done, that will be positive. And also leukocytosis is seen, that is your increased neutrophilia is seen. Now what is the treatment of this is treatment is your antibiotic. Now before giving an antibiotic, you have to understand which bacteria it is. By doing CBC and your C-reactive protein, you get to know that there is a bacterial infection. To identify that specific bacteria, you have to take swab cultures, that is from the pharynx of the saliva, and you have to culture them. Treatment would be penicillin, doxycycline, and cephalosporin. If people are allergic to penicillin, they can be prescribed with cephalosporin. Mucoprocin or mupirocin is a topical ointment. Mupirocin is a topical ointment. Sorry for the pronunciation. Mupirocin is a topical ointment which relieves the discomfort. Okay, for the usually applied on the rashes. So that's all for scarlet fever. Now the next topic is noma. What is noma? Noma is a rapidly spreading gangrenous stomatitis with polymicrobial opportunistic infection. So noma is again a bacterial infection, but it is a type of gangrenous infection. Okay, it is polymicrobial and opportunistic, caused by components of the normal flora that become pathogenic during periods of compromised immune status. Now what are the predisposing factors? That is your poverty, malnutrition, dehydration, derived from infection, that is diphtheria, dysentery. It could be, these are all your predisposing factors, not the exact etiology, just the predisposing factors like poverty, malnutrition, pre-infection, poor oral hygiene, malignancies, immunodeficiencies could lead to this noma. Clinical features in this noma is, it is common in children. It occurs in 5 stages. First is your acute necrotizing gingivitis, and then there is edema, then there is gangrenous stage, scarring, and sequelae stage. Noma begins, this is like a story of the pathogenesis. Usually the pathogenesis is not asked, or you can also listen to it like a story. So noma begins as a small ulcer on the mucous membrane, okay, which involves one or more interdental papillae. Let's just say this is one teeth and this is the other teeth. This is your gingiva. Okay, so it involves your interdental papillae, and then there is an ulcer on the gingiva involving one or more interdental papillae. Then the first sign is your gingival bleeding, followed by your fetid odor, then increased salivation, fever is all present. So gingival bleeding, fetid odor, increased salivation, and fever. All these are the symptoms of Noma, initial symptoms. So first there is an ulcer in the gingiva which is causing gingival bleeding. Then there is odor, increased salivation, fever. After 1 to 2 weeks, this ulcer rapidly spreads and involves the surrounding tissues, jaws, lips, and cheeks. Okay, the swelling or edema in the face by gangrenous necrosis. After once the ulcer spreads the tissue to the jaws and the lips, cheeks, then there is edema on the face by gangrenous necrosis. Initial site is the area of stagnation. So initial site is the area of stagnation around fixed bridge or fixed bridge. Okay, so there is initial area of stagnation around the fixed bridge. So it affects the ulcer spreads to the jaws, lips, and cheeks. Then there is edema in the face followed by necrosis. That's all you need to know. Then the overlying skin is inflamed, edematous. Then there is a line of demarcation between the healthy tissue and the dead tissue, after which the jaw is exposed. Then there is commencement of the gangrene. Then buccal fat pad is also exposed. This gangrenous tissue is extremely foul in smell and trismus occurs. Finally, disfigurement and with disfigurement of the child with fusion of maxillary and mandibular bones. Symptoms is high fever during the course of the disease. Treatment is before the availability of antibiotics. Noma was mortality rate was 75%. After the antibiotics, it has better prognosis. We wouldn't say it has an excellent prognosis or something, but it is having a good prognosis. Treatment of malnutrition can be done and predisposing factors can be treated. So that's all for Noma. I don't think is really asked much, so you can skip that also if you want. But Scarlet Fever is very important. Two phenomena in Scarlet Fever are asked: strawberry tongue and raspberry tongue. Okay, thank you for watching. Bye.